Hi everyone, this is Hani, one of your ultrasound faculty, and I'm going to spend some time talking with you today about musculoskeletal ultrasound and how to best incorporate this helpful tool into your everyday emergency medicine practice. Just a quick reminder and plug, all of our RESUS lectures, along with UCOM presentations and other resources, are all listed on our website, madtownsano.com. Check us out or scan the QR code here to get there. A brief word about musculoskeletal ultrasound. It's so hot right now, and that's because MSK ultrasound is a really low-cost tool and has very few technical limitations. It's also comparable to MRI, and it allows you to perform real-time and dynamic exams on affected areas. And plus, you have the contralateral side to compare, which is often a limitation of MRI. What I want you to take away from this lecture is to know that MSK ultrasound is really the future of ultrasound, and I'm really excited to talk with you more about this today. I'll also start off by saying that there are many different applications for MSK ultrasound, and ultimately each of these can be its own lecture series in itself. So I'm going to briefly touch on some of this today, and I hope that I can leave you feeling inspired. To start, we'll look at just the basics of musculoskeletal ultrasound, how to perform the exam, and some tips that I've learned along the way. Then we'll look specifically at muscles, tendons, bones, and joints. And then last, we'll delve into some of the procedural applications and where I think that this could be the most useful for you. To start with the basics, the probe that you want to primarily use is the linear probe. It's a very superficial, high-frequency probe and allows you to see the superficial structures pretty clearly. You also want to make sure that you're in the MSK mode on the machine, and that really does help to optimize your images so that they're most ideal. You can use the curvilinear probe for meatier patients or for deeper structures, like hip joints, for example. Musculoskeletal ultrasound is actually pretty easy. You basically put the probe where it hurts, and then you put the probe where it doesn't, and you compare the two sides. When you're scanning, you want to make sure that you grab the images in at least two planes, a long and a short axis. And I would also advocate that you always compare the contralateral side to the affected side, because it really helps you to figure out what is going on. We'll briefly review the layers of the skin and soft tissue. At the very top here is actually the dermis and the epidermis. Right beneath that is the subcutaneous tissue here, which is fat, connective tissue, etc. Following that, you'll see the superior muscle fascia, which is this bright white line here. Beneath that, you'll actually see muscle, which are kind of these striated lines that you see here. And then last, and the deepest structure that you'll see, is this hyperechoic line here, which is actually bone, which casts this dark anechoic shadow behind it. When we're doing musculoskeletal ultrasound, you really want to pay attention to the muscles and the bones, but also know that some of the tendons are actually pretty superficial structures and may sit towards the top of the screen here. It's important to know your anatomy wherever you're scanning and what is in the area of interest or in the area of the patient's pain. And honestly, I'm not by any means an anatomy expert. I often have to look this stuff up too. So if I know that I'm going to do this exam, I'll actually quickly look up an image of where the tendons insert, where the bursa of that joint are, etc., so that I know what I'm getting myself into. A couple other tips when performing MSK ultrasound: you want to use light pressure. That can actually really show you where the area specifically is that the patient's having the most pain. Next is this can be done as a dynamic exam. You can actually have the patient move the joint slowly and examine the anatomy closely, like you see here. This is the humerus that you see here, and when the patient externally rotates the arm, that actually reveals the subscapularis tendon here. So don't hesitate to have your patient move the affected area to see what it looks like under ultrasound in real time. Next is you can use a water bath, so just know that this will actually allow you to see superficial structures much more clearly. There's these three different techniques that I've seen with water baths that are performed. The one that I like the most is actually filling up a glove with water and ultrasounding through the glove. It's important when you do this to put gel actually on both sides of the glove, so put gel underneath the glove and on top of the glove. You can have the patient put their affected hand or foot into an actual bath of water. The probe itself is waterproof up until about this point, so you can submerge the probe into the water bath itself. And then last is you can use a bag of saline to ultrasound through that. Here's what the water bath looks like. This was an example of a finger ultrasound performed by Dr. Schmidt earlier this year. So what you're seeing here is the finger in the long axis view, and you're seeing the finger in the short axis view here. So you're seeing the epidermis and the dermis layers here, the subcutaneous tissue, connective tissue, tendon here, and then the very last structure that you're seeing all the way on the bottom here is the bone. And then last, and I've said this throughout the year, you absolutely need to be using a lot of gel. When you're ultrasounding bones and joints and tendons, there's often a lot of divots, so using a lot of gel will actually create a medium between the patient's skin and your ultrasound probe so that you don't lose contact with the patient. We'll jump into what some of this looks like now. We'll start with muscle, then we'll look at tendons, and then last, bones and joints. So looking at muscle in the long axis view actually appears as these bright linear lines throughout kind of a hypoechoic field. And in the short axis view, the texture changes. So it actually looks like what they call the starry night pattern, which is these kind of speckled bright white stars within a darker hypoechoic background. When you're evaluating muscle, you want to see that the bands all kind of look linear and they look together and composed. Here's an example of a patient with the quadriceps muscle rupture. First, notice that this is actually done with the curvilinear probe, which is again okay to use. Next, pay attention to the muscle fibers themselves. What you're seeing here is that they're not nice and continuous throughout. Here, this portion looks okay, but you're also noticing this anechoic round structure here, which actually represents a hematoma from a muscle rupture. We'll next talk about tendons. Here's an example of a quadriceps tendon. This is actually pretty easily obtained. You take the ultrasound probe, put it just above the patella, and then you scan upwards with the indicator towards their head. Tendons themselves, they're not quite as meaty as muscles, and they appear as these bright echogenic linear bands that can actually vary in thickness depending on the location. In this example, you're actually also seeing some fluid beneath the tendon itself, but you notice that the fibers of the tendon look nice and continuous throughout. So this actually represents a bursitis. Again, the tendon itself appears to be intact, but their fluid underneath the tendon is actually representative of the suprapatellar bursa, which sits just beneath the quad tendon. Here's another example of the patellar tendon. So this is done by putting the ultrasound probe just now beneath the patella and scanning downwards towards the tibia with the indicator up towards the patient's head. So what you're seeing on your screen here is at the start of the screen, this right here is actually your patella right here. This is our patellar tendon, which is this band that extends all the way down until it inserts onto the tibia there. And here is another example of a patient's Achilles tendon. The Achilles itself is very superficial, so you don't quite need as much depth as you may on some of the others. Again, the fibers of the Achilles tendon should look nice and continuous in appearance all the way above. And it's also important to catch the Achilles at the insertion of the calcaneus because sometimes small tears can actually begin there. As an aside, there's a fat pad that sits just beneath the Achilles. That's actually called the Kager fat pad. And there's also a very small bursa that sits just beneath the Achilles in the calcaneus, which sits right here. And that's the retrocalcaneal bursa. So if you see something like this, this is actually what we call a retrocalcaneal bursitis. And don't forget, you want to scan in two planes. Now here's what the Achilles looks like in the short axis view. So instead of seeing that long band-like structure, what you're actually seeing is this ball of fibers in kind of this round cross section at the very top of your screen. Tendons have this really interesting phenomenon that we absolutely need to talk about. This is called anisotropy. Basically what that means is that the ultrasound image of a tendon will vary depending on the angle at which you're scanning. This is actually normal. If you have a tendon injury, it will actually not demonstrate anisotropy. And here's how it works. Basically, if you ultrasound the tendon head on, the ultrasound waves get sent out from the ultrasound, they bounce off the tendon, and 100% of the ultrasound waves will get back to your probe. So your tendon will show up as bright. But if you're slightly off center, the ultrasound waves will get transmitted to the tendon, and then they'll get reflected away from the probe. And some of the waves actually don't make it back to the probe. So therefore, the tendon itself will look a little bit darker. This is a completely normal feature of tendons, and it's really important to know and to understand, because if not, it can lead to imaging errors. Here's an example of what that looks like. So this is a biceps tendon. This is actually obtained by putting the probe right at the patient's shoulder in the transverse orientation. What you're seeing here is this is all the humerus, and the outer part is the greater tuberosity of the humerus, and the inner part is the lesser tuberosity of the humerus. And in between, you have actually the bicipital groove, which you see here. And within that itself, you're seeing the biceps tendon here. And what you're noticing is as I carefully fan the probe, that color of the tendon is actually changing from a bright white to a darker color. That is what the anisotropy is, and that is actually a completely normal feature of tendons. Here it is again, but with the patellar tendon. Again, I'm very slightly carefully fanning to see that the tendon changes color from kind of this lighter to darker appearance. Again, that is completely normal. If you think you see something like a tendon tear, bursitis, or a fusion, it's very important to do a very careful fan throughout and fan again and fan again, because the pathology does not change color, and a hematoma or a tendon tear or something like that will actually stay looking dark. Here is an example of a quadriceps tendon injury. Again, look at the tendon very carefully. It should be nice and continuous throughout. But what you're actually seeing here is now the tendon becomes thickened and irregular in appearance, and you're actually seeing this dark anechoic stuff in the tendon itself, and that is indicative of hemorrhage. And notice that when we're over that area, we're actually doing a very careful fan to see if it's changing colors, or to see if it has anisotropy, and it does not. So therefore, it is pathological. And here is another example. Now you're looking at another quadriceps tendon, and as we're scanning from the patella upwards, you notice that the tendon fibers appear intact and normal. But as we progress upwards, you're now noticing this dark anechoic fluid collection sitting right above the tender. It's a little unclear what this might be. It might be indicative of tendinosis or chronic inflammation of the tendon, or a small partial tear with this layering hemorrhage in the tendon sheath itself. But again, notice that when we're at this point, we're doing a very careful fan to see if it's changing color, and we're noticing that it does not. We actually see this pretty commonly with the Achilles tendon. So what you're seeing here is the Achilles inserting onto the calcaneus directly here. This anechoic collection beneath the Achilles tendon and just above the calcaneus, a lot of people would mistake for something like a partial Achilles tendon injury. However, this is another example of anisotropy. You can correct this with the heel maneuver. So have the patient hyper dorsiflex their foot and do a very slight fan of your probe, and you'll actually see that go away, and you'll see the fibers now extend and completely insert onto the calcaneus there. Here is another example. So this is somebody who is actually painting, who is spending a lot of time on his knees, and presented to the ED with significant right knee pain and swelling. So what you're seeing here is quite a bit of fluid that sits right above the patellar tendon here, but the patellar tendon itself appears to be nice and intact. This fluid, however, lacks anisotropy. This is actually bursitis. Again, remember the bursa and where they sit in the knee. So just above the knee and above the patellar tendon, you have both the prepatellar bursa and the subcutaneous infrapatellar bursa here. So this is a normal tendon, but with an overlying bursitis. When it comes to tendons, we need to think about it as partial or complete ruptures. Partial tendon ruptures will actually show up as fluid within the tendon itself that is non-anisotropic, or fluid around the tendon sheath or plane, like we saw in the earlier example. Whereas complete ruptures will show up as separated tendon fragments with surrounding hemorrhage. You may actually also see retraction of muscle, and then you'll see posterior acoustic enhancement as the ultrasound waves go through that area of hemorrhage. And here's what a complete rupture looks like. So this one's pretty obvious. What you're seeing is this nice break in between the tendon fibers here. That anechoic collection in there is actually indicative of hemorrhage, and everything behind that appears to be bright and white. That's that posterior acoustic enhancement that we talked about. And here it is in the short axis. That nice ball of tendon fibers that we see right here goes away and is replaced by this dark anechoic collection here, which is indicative of hemorrhage. And here's an example of an Achilles tendon rupture. So again, what you're seeing here is the Achilles inserting onto the calcaneus here. This fat pad that sits behind the Achilles, that's the Kager's fat pad again. And this small anechoic collection beneath the Achilles and just above the calcaneus here, that's that retrocalcaneal bursa, which can be normal. But what you're actually noticing is that the Achilles tendon itself appears pretty thickened and irregular. The tendon appears to kind of look a lot more hypoechoic in this area as well. So this is all indicative of an Achilles tendon rupture. So just how accurate is ultrasound? There have been a couple of reviews looking at this. When it comes to full or complete tendon injuries, ultrasound is actually 100% sensitive for that. But because of the reasons and because of the difficulty with anisotropy, partial tendon injuries are much more difficult to pick up. Ultrasound is about 50% sensitive in these cases. So my takeaway from this is that if I'm concerned somebody may have a partial tendon injury that I'm unable to pick up on ultrasound, I'll actually just refer them to sports medicine or orthopedics as an outpatient. We'll talk very briefly about tendinosis. Tendinosis is actually mixed up quite commonly with tendinitis. Tendinosis is kind of that more chronic knee pain or shoulder pain that we may encounter in the ED, and that's actually the result of degeneration of a tendon's collagen in response to chronic overuse. Tendons will actually appear to be thickened, nodular, and hypoechoic, or have calcifications. And here's an example of that. So this is a patellar tendon, and on the left, what you're seeing here is that this tendon is normal and appears to be in normal thickness, whereas on the right, that tendon appears to be thickened, portions of the tendon itself appear to be anechoic, and you're actually seeing this bright white structure here that's actually a calcification. So together, the thickened tendon, these hypoechoic areas, and this calcification are all indicative of tendinosis. We'll move on and we'll talk about bones and joints. So bones on ultrasound are pretty easy to see. They show up as these bright white hyperechoic lines that cast this acoustic shadow behind them, and you're not able to see anything behind the bone. This is an example of a patient with rib fractures missed on x-ray. So on the left, what you're seeing is a normal non-tender rib, and you're seeing this nice bright white line that appears to be continuous throughout. Whereas on the right is the spot that the patient's tender in. And what you're seeing is a disruption in the cortex of the bone here and about here, which is indicative of a non-displaced rib fracture. Here is an awesome distal radius fracture picked up by one of our residents. So what you're seeing here is the radius here, nice and clean, crisp line, and then this disruption in the radius, which you see here. So this is an obviously pretty bad fracture. Some of the newer stuff that's coming out now is actually looking at the use of ultrasound in the identification of occult scaphoid fractures missed on x-ray. Some of the preliminary literature that I've been seeing shows that ultrasound appears to be about 90% sensitive for this. And here's what it looks like. You essentially just put the probe in the snuff box, and this right here is the scaphoid. And what you're seeing is this disruption in the scaphoid throughout. It's not that nice, clean, linear line that we saw in the earlier example. When it comes to looking at the joints itself, you can do this in a couple of different ways. So in the knee, we assess both the lateral joint and the medial joint. So this is again done by putting the probe in the lateral aspect of the leg with the indicator up towards the head. So what you're seeing on this view is the femur on the left side of the screen here and the fibula on the right side of the screen here. So you'll see one bone end and another bone start. And if there's no black anechoic collection in this space, then there is no joint effusion here. You'll actually also see the same thing on the medial knee, so the exact same technique, just done on the opposite side of the knee. And what you're seeing here is, again, the femur and the femur bone dive down, and then the tibia bone here start. And they almost form this somewhat like seagull appearance. And again, this is a normal joint. I'm not seeing a dark anechoic collection in here. So these joints do not demonstrate evidence of a knee effusion. You can do the same thing on the ankle as well. So essentially you just put the probe on top of the dorsum of the foot here with the indicator up towards the head. So what you're seeing on the left side of the screen is the tibia here, and the tibia dive down, and then a new bone start, which is actually the talus here. And in between them, this is actually the joint space. And in this example, there is no evidence of effusion here. Here is an example of an ankle effusion in a different patient. So again, on the left side of the screen, here's the tibia, and then on the bottom part here, this is all the talus. And what you're seeing here is a nice effusion right beneath or in between the tibia and the talus. There's also another really interesting thing here, and what you're seeing is actually a blood vessel right on top of this. So that's important to know because it can actually help to guide your arthrocentesis. So you would know not to go through this vessel in order to get to this effusion. You can actually do the same thing with the elbow joint itself. You place the ultrasound probe posterior to the elbow with the indicator up towards the patient's head, and what you'll see is something that looks like this. So on the bottom part of my screen is my humerus because my indicator is on the left side of my screen, and on the right side of my screen is actually the ulna. So these two bones come together to form the elbow joint, and I'm not seeing an elbow effusion here. As an aside, you're also seeing a glimpse of the triceps tendon, which inserts onto the ulna right here. And here is the patient's elbow on the affected side. So what you're seeing again is the humerus down here, the ulna at the top of your screen here, and in between this kind of anechoic collection sitting in between, which is indicative of a joint effusion. We've talked about a lot of awesome applications of MSK ultrasound so far, but where I think it's probably the most useful are the various procedural applications, and specifically arthrocentesis. Ultrasound has really changed the game. I'll basically ultrasound any joint before I tap it now and map out exactly the direction that I want my needle to go. Look, you can memorize this boring, annoying table, or you can honestly just pull this up before you do an arthrocentesis, stick the ultrasound probe on the joint that you're interested in, and map out exactly where your effusion is and how you want your needle to advance. You can do this in one of two different ways. The first is to actually find the effusion in both the long and the short axis view. Get the effusion in the middle of your ultrasound screen, and then mark with a marking pen each side of the ultrasound probe and create 4 little dots on the patient's joint like this. Connect them, and the point at which they all meet is the spot at which you should inject. You can also do this ultrasound guided, but please, if you do it, use a sterile probe cover. Essentially what you can do is put the ultrasound in the long axis view and use the inline technique. So you actually have your needle going in at the same direction or parallel to your ultrasound probe itself, so you can watch and visualize your needle going in the entire time. And before I start, I usually map out the trajectory. So this is that ankle from earlier. Again, here's the tibia, here's the talus, and in between them is this effusion. I no longer see that blood vessel in the way. And at the top of my screen is my needle tip here. So I know that I'm on the right track. You can actually, in that in-plane technique, watch the needle as it goes into the effusion directly itself. And you'll also know when you're in the effusion itself and that you haven't passed it or anything like that. There's been a lot of studies looking at this, showed that using ultrasound increases accuracy. It actually increases aspiration volume. It decreases pain for the patient, and it really doesn't take any difference in time. The last procedural application that I've been using this in is actually in cases of shoulder dislocation. So the way that you would do this is you'd actually place the probe in a transverse orientation in the posterior aspect of the shoulder. And it's pretty easy. You just need to identify 2 structures, the scapula and the humeral head. So what you're seeing here is the ultrasound of this patient's shoulder. And on the left side of my screen is the scapula here. And then on the right side of my screen is the humeral head here. And I'm actually having the patient do an external and internal rotation of their arm so that I can visualize the humeral head within the glenoid and the joint space here. And this is a case of a dislocation that Dr. Stample actually recently took care of. So what you're seeing here is this is actually the patient's left shoulder, so an opposite shoulder. But again, this is the scapula here, and this is the head of my humerus here. You see that the two are pretty disconnected, and that this is actually further anterior because I'm in a posterior approach. So this is the patient's back, this is their scapula, and this is the humerus here. So this is actually an anterior dislocation. You can also save yourself and avoid doing an x-ray post-reduction and just do an ultrasound, and it'll give you the same information. So we talked a lot about musculoskeletal ultrasound. At the end of the day, there are lots and lots of applications that you can use this in, and it's really important to know or to look up your anatomy. When we talk about tendons, again, beware that anisotropy that we talked about, and remember that that's a normal finding of tendons. Ultrasound helps you to get a real diagnosis, and I actually think it's better than MRI because you can compare it to the unaffected side. And again, before you do any sort of procedure, especially an arthrocentesis, you should ultrasound it before you stick a needle into it.